Dokter Jaka, kamera standby dok.
Nyeri pada dada. Sulit bernapas bagaikan berada di dalam air. Merupakan beberapa gejala yang dialami oleh penderita pneumonia. Pneumonia menginfeksi 450 juta orang per tahun di seluruh dunia. Singkirkan kekhawatiran. Nafas baru dalam terapi pneumonia telah hadir. Moxifar. Dengan kandungan moxifloxacin yang direkomendasikan untuk terapi community acquired pneumonia, Moxifar efektif memperbaiki gejala-gejala community acquired pneumonia. Moxifar aman untuk pasien usia lanjut dan gangguan fungsi ginjal. Moxifar lebih cepat mengatasi perbaikan klinis dan tingkat kesembuhan pada pasien. Moxifar, it's time to breathe relief. Moxifar, breath of relief.
Assalamualaikum warahmatullahi wabarakatuh. A very good evening to fellow colleagues all over the world. My name is Dr. Jaka Pradipta. I'm your host for today's webinar. On behalf of we are pleased to welcome all of you to the second RESPINA Global Sharing, Advancement of Diagnostic and Care in COVID-19 Pandemic. As we know that COVID-19 has been spread all over the world since December 2019, cumulatively 28 million COVID-19 cases and 900,000 deaths has been reported globally. To date, many vaccines or medicines for COVID-19 are still under investigation. So we need a global collaboration, working side by side to accelerate the development of safe, effective, and affordable COVID-19 diagnostic and therapeutics. So tonight, we are inviting experts from all around the globe to share their experience in combating the COVID-19 disease. And today is a very special day because we celebrate RESPINA's 22nd birthday. So I want to give appreciation and congratulations to Dr. Wayuningsi Suharno, the President of the Respiratory Care Society, Profesor Menaldi Rasmin, Profesor Hadiar Tomangunegoro, Dr. Ida Bernida, Dr. Prasna Paramita, Dr. Suci Mariono, Dr. Rita Rogaya as a RESPINA Advisory Board. And a very warm welcome on behalf of the organizing committee to our guest speaker, Professor Liu Fengming from China, Dr. Melvin Tai Chikiang from Singapore, Dr. Francisco Diaz from USA, Dr. Vinci Edi Wibowo, and Dr. Dewi Yenitasari from Indonesia. And we appreciate you taking time of your busy schedules to join us here today. And last but not least, I would like to say thank you to all participants from all around the world who participate in this event. And I want to remind, if you have the registered, please remember to fill and submit the post-test for electronic certificate after the webinar. And if you have any question, please write down your question in Q&A session, and please mention the name of the speaker. And first, we are going to hear welcoming speech from the President of the Respiratory Care Society, Dr. Wayuningsi Suharno, pulmonologist. Dr. Wayuningsi is the President of the Society of Respiratory Care Indonesia and a pulmonologist and COVID-19 team leader at Pertamina Central Hospital, Jakarta, Indonesia. Dr. Wayuningsi, the time is yours.
Thank you very much, Dr. Jaka. Distinguished guest participants, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. First, thank to God, we are in good health. We are always in good health. I hope we always in good health. Good morning, good afternoon, and good evening to our honorable speaker and all participants. Thank you very much for participating the second RESPINA Global Sharing Advance of Diagnostic and Care in COVID-19 pandemic. And special thank we would like to forward to honorary speaker, Professor Lau Mengbing MD from China, Dr. Melvin Tai Chikyang, MBBS, MMD, MRCP, FMAS from Singapore, Francisco Diaz, MD from USA, Dr. Dewi Yenita Sari, Clinical Pathology from Indonesia, Dr. Vinci Edi Wibowo, Pulmonologist from Indonesia, and Dr. Dian Prastiti Utami, Pulmonologist from Indonesia. And also thank you to committee and the Daria Varia company for support this webinar event. It is great pleasure to join with you today on the sharing knowledge about the diagnostic and care of COVID-19, such as laboratory and advanced bronchoscopy, and how to manage the oxygen with patient with COVID-19, and autopsy finding on the patient with COVID-19. And the last but not least, the interesting is the safety medical personnel and patient during this pandemic, sharing from the speaker from external experience. And this evening, a webinar will be held as part of a serial event to celebrating the 22nd anniversary of RESPINA, which RESPINA couldn't be at this stage without all the support of all the participating and support from all of you. Together, we will keep RESPINA lead in respiratory care to build a healthy society. Pada sore hari ini, RESPINA diselenggarakan hari jadinya yang ke-22, dan RESPINA ada oleh karena dukungan dari semua pihak dan kerjasama yang selama ini kita bangun, mudah-mudahan berjalan dengan baik dan bertambah baik. RESPINA, bersama RESPINA kita membangun manusia dan masyarakat yang sehat. I hope you will be benefit from this webinar. Selamat berwebinar, semoga bermanfaat untuk kita semua. Saya akhiri dengan wassalamualaikum warahmatullahi wabarakatuh. Terima kasih, Dr.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Wayoningsi for the speech. And now we are welcoming our moderator for today, Dr. Dian Prastiti Utami, pulmonologist. Dr. Dian is a chairperson of the first RESPINA Global Sharing and the second RESPINA Global Sharing, and she is a pulmonologist at Pertamina Central Hospital, Jakarta. Dr. Dian, the time is yours.
Hello, Assalamualaikum warahmatullahi wabarakatuh. Good evening, Indonesia and all around the world. Dr. Jaka Pradipta, thank you for the introduction. Today, we are having a webinar, the second RESPINA Global Sharing Advancement of Diagnostic and Care in COVID-19 Pandemic. We have 5 speakers, and for all the for all of the attendees who already present in this webinar can ask question. There's a question and answer section below the screen. You can type the question there. The speakers can type their answer there, and some of the question will be asked live. And now, without further delay, I would like to invite our first speaker who will be presenting paper about the medical safety and patient safety in global 19 pandemic, Dr. Vinci Edi Wibowo. Dr. Vinci Edi Wibowo, pulmonologist, is the vice chairperson of the second RESPINA Global Sharing. He is the pulmonologist at Mitra Keluarga Hospital, Kelapa Gading, Indonesia. Dr. Vinci Edi Wibowo, the time is yours.
Thank you, Dr. Dian. Let me share my presentation first. So today I will talk about the medical personnel and the patient safety in the COVID-19 pandemic. As we all know, the COVID-19 is already declared as a pandemic as of March 11 of 2020. And since then, unfortunately, we already lost about 100 doctors and probably more of our healthcare workers in Indonesia. And in worldwide, there's so many healthcare workers has been a victim of COVID-19 since then. So if you talk about the safety for both patients and the medical personnel, we talk about how we can prevent the transmission of the virus, usually from patients to patients, and then from patients to the medical personnel, even between the medical personnel, and even from the doctors to the patient. It can be happens, the transmission in that way. So there's 3 main topics I want to talk about preventing the transmission of the virus in the COVID-19 actually. And the first we want to talk about is always about the personal protective equipment. So we talk about the mask, about the body suit, about the face mask, and we also have many things to think about the personal protective equipment. Is it about the properly use of the equipment? About the supply, do we really have enough supplies? Because many of us has been reused the equipment, like the mask. In my hospital, I cannot use it more than about 2 days after that. And then we have to change the mask. It is very risky actually. And also we can talk about the quality, about the equipment. And so many guidance about it. I cannot talk about it in this slide because I don't have much time about this. In our government, we have guidance about the PPE. This is released in April. Even the WHO have released a guidance about the PPE. even the CDC has released a guidance. So if you want to know about how the properly use of the PPE, and I'm sure most of you already knows because it's about 6 months since the pandemic has been declared by the WHO. So by now, if you don't know how to use the proper use of PPE, then you should learn how to use it properly. And this is the newest release, the guidance to protect our doctors because we already lost so many healthcare workers. This is released in August in 2020. You can search it online if you want, and you can read it because the more details is described in this guidance. And secondly, I want to talk about how we can control the crowd. It's not only the patients, but also the healthcare workers, because as we all know, we are a social human. We cannot avoid having a socially interactive with our nurse, with our another person in hospitals. So we always have to focus about physical distancing, but in general, it's not very easy to do. So it can be implemented, but it always has to be in our mind. And so many things about crowd management. It is avoid gatherings, so to reduce the amount of patients in our hospitals or probably in your clinic, and probably use a telehealth service, and we call it telemedicine in Indonesia, and also about environment and control. And we can make the ventilation, we can have disinfection in our environment. And once again, all of that, you can see it in online. There is so many guidance about it from CDC, from in our government, from Department of Health. And so what's the question? The question is, what can be improved? I'm sure all of us already implemented this many things to protect ourselves, but you have to question in your mind what can be improved. So we can protect ourselves, but all of that is only preventing the virus from entering our body. But sadly, the virus is very easy to enter our body. This is a research, a cohort study from March to April in 2020. It said, despite wearing good PPE, the healthcare worker still has 3 times at risk of COVID-19 infection. And this is a report from our laboratory in the University of Indonesia. They said 8% of the positive samples were healthcare workers. And also this is the report from London. This is even more worse. It showed that 44% show evidence of SARS-CoV-2 infection either by RT-PCR or serology. That's too much. And again, this is from the New York City area. They said that 13% of healthcare personnel were seropositive, and about 2,186 were PCR positive. This is from March to June of 2020. So it's very easy for us to get the virus. As a medical personnel, as a doctor, as a pulmonologist, I'm sure sometimes in this pandemic, I will get the virus. So how can we face the virus then? So the question is, when we cannot stop the invaders, then we have to fight the invaders from inside our body. So that's why we don't make our body weak. So don't weak your immune system. That's the second line of defense to fight this virus. So there's 3 major things I focus how we can weaken your immune system. The first is the fatigue, it's the lack of sleep, and also stress. And this is the report from 12 study. They call it a systematic review and meta-analysis. It said that 23.2% of the healthcare workers have anxiety, and 22.8% has depression, and even worse, 38.9% has insomnia. It's also mentioned in our guidelines, in our news guideline in chapter 4, how we can prevent all that. There's 3 major things we can prevent to prevent the fatigue. The first thing is the work shift management. So we cannot work more than probably 12 hours, and we have to have enough sleep, probably about 7 to 8 hours of sleep. And also having a good teamwork is also can help to reduce the workload. And the stress management is easier to say than done, because the only one who can manage stress is by yourself. So this is my warning to you. You have to know your limit. Don't push yourself too hard, because if you have lower your body immune system, then there's more higher chance for you to get an infections. And by resting yourself, you can fight better for another day. Okay, thank you for your attention. Back to Dr. Dian. Assalamualaikum warahmatullahi wabarakatuh.
Yes. Thank you very much, Dr. Vinci, for the presentation. I would like to extend our condolence for all the medical personnel who's already passed away because of this COVID-19 disease, and also to all the family who lost their family members because of this disease. Next is our second speaker, Dr. Dewi Anitasari, a clinical pathologist. She is a clinical pathologist at Persahabatan Hospital, Jakarta, and the head of Central Laboratory, Persahabatan Hospital, Jakarta. Dr. Dewi Anita, the time is yours.
Thank you, Dr. Dian, for your kind introduction. Okay, Assalamualaikum warahmatullahi wabarakatuh. Good evening. First of all, I would like to say thank you to RESPINA and to the President of RESPINA Society, Dr. Wahyuningsi Suharno, pulmonologist, who gave me opportunity to share my study. And I also would like to say thank you for my teacher, Prof. Menaldi, and Dr. Rita Rugaya, the director of Persahabatan Hospitals, who always support the study in our hospitals. I also would like to say my greetings to all honorable speakers and audience. Hope that we can discuss this study together. Okay, my study is about the clinical application of IgG SARS-CoV-2 in Persahabatan Hospital. The outline of this presentation is what is the problem and how is the study, what is the result, and how is the application of the study. The main problem in our country is the serology testing based on lateral flow method, or as we know as rapid test, is spreading all over Indonesia and it's uncontrolled. So this right now we have instrument-based serology testing, which is now introduced to our country. Can it be used as a complement to PCR testing? That's the first question. And the second question is instrument-based serology testing reliable and accurate? And the third question is what is clinical application for serology tests? And the other problem is because this new test, it's instrument-based SARS-CoV-2 IgG and IgM. So as a laboratory, we have to do a method validation by CV and SD. And then we have to do the clinical performance by sensitivity and specificity. And how is the clinical application of the serology testing? And this, the other problem of the RT-PCR from nasopharyngeal swab is we can know that the sensitivity of RT-PCR from nasopharyngeal is only 60 to 70%. So it really depends on the pre-analytic and the analytic factors. And then the viral shedding in nasopharyngeal, if it's not acute, then the virus is not there in the nasopharynx, so the result will be a false negative. And I would like to show a very good leaf plot diagram of RT-PCR testing by Professor Jessica Watson from Bristol, UK University. In this leaf plot diagram, he make a leaf plot diagram based on 70% sensitivity and 95% specificity of RT-PCR. In this leaf plot, we can see that if a person has a pre-test probability of COVID-19 50%, then if he get negative result from RT-PCR, it means that he or she still has the chance to have a COVID-19 infection as 25%. But if he or she has a pre-test probability of COVID-19 of 90%, then if he or she get the negative result of COVID-19, if RT-PCR, it means that he has a possibility 75% that he still can be infected by COVID-19. And another diagram from Prof. Jessica Wesson is, I really like this beautiful diagram. So he make a chart. If there is 100 people, 80 people have COVID-19 and 20 people do not have COVID-19, and they all are tested with RT-PCR. And because the RT-PCR sensitivity only 60 to 70%, so the only 57% will have a test positive for COVID-19, and the other 43% will have a result test negative. And from 57% who has a true positive result, 1% has false positive because of contamination. And then this person has the consequences. We told him or she or her to self-isolate whether she would be safe to go out. But for 24% who has test negative for COVID-19, they actually have COVID-19 disease. And we told them to go free and then not to self-isolate, and they can infect more people. But 19% are true negative. And 19 people are true negative. So this study, now I would like to enter the study. So I'm using Architect SARS-CoV-2 IgG. It detects IgG and SARS-CoV-2 serum and plasma. It detects the nucleocapsid protein. The interpretation of this reagent is if the index of S per C is lower than 1.4, it's negative, and more than 1.4 and more is a positive. The detection limit of this test is 0 to 9.9, but it's not stated, but I never get a result more than 9.9, and dilution is not recommended. And then I'm also use Architect SARS-CoV-2 IgM, but this reagent is research use only and just released in US on August 2020, not available in Indonesia yet, but in Persahabatan Hospital, we have the opportunity to test this reagent. It detects IgM SARS-CoV-2 in serum and plasma. It detects IgM2 spike protein, but this reagent is investigation use only. This is the study. So we are taking samples from 53 patients who has a PCR positive and 10 patients who has PCR negative. So what do we do is we do the day 0 from PCR test. We test the SARS-CoV-2 IgG and IgM, and then we go to the next day 1 and day 3 post PCR test. We also check the IgG and IgM, and then we test again at discharge or when the patient comes at outpatient ward. And for PCR negative, we only do the day 0 PCR test. And this is the result. For IgM SARS-CoV-2, we can see that from at day 0, from 53 sample, we have only 36 patients who has positive for IgM. So the sensitivity for the test at day 0 from at the patient when they come to the ER is 68%. And then and then we follow up at day 1 or 3 according to the sample that we have, that only 25 patients from 33 patients has a positive IgM. It means the sensitivity is 76%. And for day more than 3, with average day is 14 days, so the sample is from day 5 to day 42 after PCR confirmation, we have a 92% sensitivity for IgM. But surprisingly, for IgG, at day 0, when the PCR test, we have a more positive IgG. result from 53%, 53 patients. So we have the sensitivity of 74% for IgG at day 0. And then for day 1 to 3, we have a sensitivity was 79%. And for day more than 3, with average 40 days, we have a sensitivity of 97%. And day more than 3, we use a sample range 5 to 40 days after PCR confirmation based on the sample that we have. And if we combine the IgG and the IgM, we can see that the IgG has better sensitivity than the IgM on day 0 and day 1, day 1 until 3 and day more than 3. This study concordance with the study with the review from Cochrane Library. They are reviewing 54 antibody study, and they also get the same result that IgG has more sensitivity than IgM at day 8 to 14 after symptom onset, and then day 15 to 20 after symptom onset, and day 22 to 35 after symptom onset. But if we combine the IgG and the IgM, we can increase the sensitivity for day 0 to 81%. So at the time when the patient comes to the emergency room, so 81% of the patient will have IgG or IgM or both positive. This is also concordance with the review from the Cochrane Library. We can see that when we combine the IgG and the IgM, the sensitivity increasing. How about the other clinical performance? We have a specificity on 10 PCR negative patient is 100%. For negative and positive predictive value, we counted based on 10% seroprevalence. We get a negative predictive value of 97.82% and positive predictive value of 100%. So if we see the percent of agreement on day 0 from 53 patients, we can see that on patient who has IgG SARS-CoV-2 positive, 32 from 39 patients who has IgG SARS-CoV-2 positive, 32 patients also have IgM SARS-CoV-2 positive. And from 14 patients who has IgG SARS-CoV-2 negative, 10 patients also have IgG SARS-CoV-2 negative. So from this percent of agreement, we can see that from these 10 patients, we would like to see the seroconversion. And then from this 7 patients who has discordance that IgG SARS-CoV-2 is positive and IgM SARS-CoV-2 is negative, what happened to this 7 patients? That's we will go through to that 10 and 7 patients. The seroconversion. Okay, from 10 patients who has PCR positive, that we can see that from IgG on day 1 and 3, one patient undergo seroconversion on day 1 to 3. The other 9 patients still undetected, IgG still undetected on day 1 to 3. But on the day more than 3, with average day 14 days, we can see that all patient has 9 patients has a seroconversion, but 1 patient stay negative. How about IgM? We can see that from this 10 patients who has a positive PCR, 3 patients undergo seroconversion on day 1 to 3. So this in this IgM, we can see that IgM is seroconverted not for long from the IgG. So this study can support this chart that IgM should be not different from, so far different from the IgG who becomes seroconverted. How about the discordance for 7 patients who had positive IgG and negative IgM on day 0? From these 7 patients, we can see that on patient 1 and patient 1, patient 2, and patient 5, there are a declining on IgG. The cutoff index of IgG are declining on patient 1, patient 2, and patient 5. And surprisingly, in these 3 patients, the IgM never detected in these 3 patients. But for patient 3 and patient 4, we can see that the IgG is increasing and the IgM becomes seroconverted on the next 1 to 3 days. From this chart, we can see that we can say that sometimes in some people, IgG appear first, then followed by the IgM. This may be because coronavirus has many type and species. Maybe this person have already cell memory cell about the coronavirus, so they develop IgG first, then IgM. But we still have we still have more study about that. So this is the conclusion of the 7 patients. From 7 patients with positive IgG result, 2 patients had positive IgM result on the next 1 to 3 days. They support that IgG appear first, then IgM, and 3 patients has undetectable IgM level. So this is one of them. So the IgG is declining, but the IgM never detected because the cutoff index for IgM is 1.0, and 2 patients has no data. So the study is concordance with another study from Andrea Paduan. In this study from Andrea Paduan, he said that the IgM is declining on day 20 to day 25, and but IgG still can detect it more than 30 days. Also, another study from Yu Jiaojin, he said that also the same thing, that the IgM is declining on day 21 to day 25 from PCR confirmation. So maybe in the 3 patients, the patient already infected more than the symptoms already there more than 20 days. So the IgM no longer detected and IgG is declining. Okay, we also want to know about the antibody kinetics. Is it right that the IgG is disappearing in day 21? So I'm taking 20 patients. I'm describing 20 patients in here. The IgM, we can see that the IgM is declining in some patients when they come to outpatient ward. So some patients still have increasing IgM because I check it in the time when patient discharged. But when patient come to visit at the outpatient ward, that we can see that IgM is declining. But the IgG, when even when the patient come to outpatient ward, the IgG is still around 4 to 6 to 7 cutoff index. We can see clearly now in the patient number 8. We can see in day 18, when patient comes for visit for at outpatient ward, we can see that the IgM is declining, but IgG still stable and cutoff index 6.05. And also again, in patient number 25, I managed to follow up until day 45. We can see that in the day 45, the IgM is no longer detected, but the IgG is still between 5.74, almost the same when they come to the hospital. Another 10 patient, we can see that, another 10 patient, we can see that when the patient comes to visit an outpatient ward, there is a declining on IgM, but when they discharge from the hospital, the IgM still in the increasing. But in the IgG, almost all the IgG is increasing except for this one patient that I told earlier, who has no detected IgM. This is a patient number 11 that we can see in the day 24, but in the day 24, when the patient comes to visit, the IgM is still detected. Maybe this is because the theory that IgG and IgM is more high in patient with the severe disease. So we can see that the cutoff index of IgM is 79, very, very high than other patient who has only maybe 1 until 10. But in the day 25, the IgM is still detected. Another patient who comes in day 22, the IgM also still detected, even though that it's already declining. So there is another theory that IgM is still can be detected in the blood until day 42. So what is the clinical application of serology testing? So on emergency room, that for patient who has symptoms specific for COVID-19 and then has radiologic imaging and other laboratory tests support COVID-19, then IgG SARS-CoV-2 positive can help screening the patient while waiting for RT-PCR test result. And then when clinician have doubt in the RT-PCR result because of its high false negative, serology testing can be a complement to for RT-PCR testing. And this I quote from CDC that for late onset disease, serologic testing can be offered as a method to support diagnosis of acute COVID-19 illness for person who present late. For person who present in day 9 to 14 after illness onset, so the viral shedding is no longer available, the sensitivity of the RT-PCR test is declining, then serology testing can be offered in addition, not to exchange the RT-PCR test. This is the CDC that I quote. And then what is the other clinical application of RT-PCR of serology testing is the paired sera. So if we use the paired sera, we can see the seroconversion, and we know the course of the disease of COVID-19. This is I quote from the Ministry of Health of Singapore. So they are using the day from seroconversion is day 7 for asymptomatic person. And for plasma convalescence, right now we know that some clinicians are using plasma from recovered patient, but we have to measure. Actually, we have to measure the neutralizing antibody, so we can know that the plasma really have the neutralizing antibody for COVID-19 to use in patient. But we can also use a proven equivalent antibody level. In this equivalent antibody level, we have to do more research. But I will quote the research from Finland. He is comparing 6 SARS-CoV-2 immunoassay to microneutralization. And I'm quoting the reagent that we are using in our hospital, that MNT titer 80 is equivalent to SARS-CoV-2 IgG cutoff index 3.5. And I would like to present some of cases, only 2 cases actually, to show the use of serology testing. This is one patient, patient S, 60 years old. He's come to the hospital with sepsis and pneumonia. The laboratory result is leukocytosis, and we can see that the NLR ratio is 16, the dimer is high, CRP is high, procalcitonin is high, the ferritin is high, but the total antibody is negative. And the patient undergo RT-PCR at the next day, it's negative. And then the other day, the second day is also negative. And then the day 7 is also negative. So this patient, so I checked the IgG, when the patient discharged from the hospital, apparently that the IgG also negative. So we can actually save some costs for RT-PCR testing with combining the RT-PCR testing with serology testing. And then this is Mrs. A. She came to contact with patient with positive result, positive RT-PCR result in 22 March. And he has fever 5 days later on 26 March and goes to the emergency room. But when he tests the IgG SARS-CoV-2, the IgG SARS-CoV-2 still negative on 6 days after contact to the patient, to positive patient. And then he comes home, he discharged from the hospital, and then she comes again on the next day. We can see that there is an increase, a little increase on SARS-CoV-2 IgG cutoff index, even though it's still negative. But the RT-PCR is positive, so the patient is hospitalized for around 3 days and discharged on day 4.
Dr. Dewi, you have 1 minute left.
Okay. And then when the patient controlled to the outpatient ward at 3 months later, the cutoff index of IgG is still high. Okay, this is the final slide. We are proposed screening in ER using IgG SARS-CoV-2, and then if negative, we can check IgM SARS-CoV-2 for the next 1 to 3 days while waiting for RT-PCR results. And serology testing can be used as a complement to RT-PCR results, and serology testing can be offered as a method to support diagnosis of acute COVID-19 illness for person who present late. Thank you for your kind attention.
Thank you very much, Dr. Dewi Anitasari, clinical pathologist. Next, I'm going to proceed to our third speaker, Prof. Fengming Luo from China. He's a consultant of respiratory and critical care medicine, West China Hospital of Sichuan University, Chengdu, Sichuan, China. Going to present a presentation about the use of bronchoscopy in the COVID-19 pandemic. Prof. Fengming, the time is yours.
Thank you, Sam. Thank you for your invitation, and good evening, everyone. Tonight, I will give you a topic about performing bronchoscopy in timing of the COVID-19 pandemic. Now we know the COVID-19 have increasing the number of infection worldwide. Now up to today, more than 28 million confirmed cases and more than 900,000 people dies about the COVID-19. And we know in China we shut down in January 23rd. That means do not go to Wuhan, do not leave Wuhan, and stay at home. That means shut down completely. And after that, we will our diagnosis cases decrease rapidly. For real time, from that time, we got daily announcement of the number of diagnoses or suspect patients in the nationwide, and we give them early protection such as social distancing, early detection, early diagnosis, and early isolation that decreased our confirmed cases rapidly. And wearing mask is required in public place. Now you can see here we shut down Wuhan airport, railway station, metro station in January 23rd. You can see no one on the street. From that day, our diagnosis cases decreased rapidly. But you can see here is a peak here. That is because our diagnosis standard changed at that day. So we diagnosis the patient in that day more than 10,000 in one day. But in 4 weeks, our diagnosis cases decreased to basically controlled. And the Fangchang Shelter Hospital, you can see that before we give the patient to the Fangchang Shelter Hospital, if a patient diagnosis and it's a mild diagnosis, we will call the patient go back home and stay at one room. But that means there are high risk of the infection of his family. But when we got a Fangchang Hospital, we give the patient a bed, food and water, and we have hospital. We have doctors and nurses in Fangchang Hospital every day. And if the patient turn to severe, we will transfer the patient to the hospital to treat the patient. But for the most of the patient of Fangchang Hospital, they will go back to home when we recovered. And you can see if you search a mask in public air in China, in Google or Baidu, you can find in China everywhere. Most of the patient, most of the people in China wear the mask. And in China now, we have no local cases for almost 1 month. But and school, third, and stores will reopen again and stay but we must stay alert about the input cases. Now we were talking about how to perform bronchoscopy during the pandemic. We know that the virus spread primarily through the droplets and micro droplets, sometimes generated by infected patient. Sometimes if you touch the surface of the since got the micro drops, that you can get the infection too. And the bronchoscopy is an other generating procedure, so we must threaten the indication for the performing the bronchoscopy. For all patients, not only the diagnosis or suspected patient. For all patients, we must ask the epidemiological history, and especially to the history of travel and COVID-19 patient contacts. That means we can find out the patient if they got a risk of the infection, and then make sure the temperature must down before the procedure. For the COVID-19 patient, most of the patients got temperature, a fever. So we must make sure the temperature before the procedure, and before the procedure, we ask patient got RT-PCR test for the examination, and the patient should be categorized about confirmed patient, proper patient, not proper patient, or negative patient. For this one, is for several months ago we do this procedure for everyone, but now in China we come back to the normal stable normal now. We don't need to do that now, and we must minimize the staff to our core team. That means there's a low observe low students and low applicants or trainees in the examining room. We don't need so much people. We must minimize the staff to the core team that they minimize the staff exposure. Patient should be wear a surgical mask in the pre-procedure area or bronchoscopy suite or the cover area. Use a disposable gowns, gloves, cups, and FFP2 mask for every person, everyone present in the procedure room to minimize the exposure. Use a personal disposal safety glass and or facial shelter for the doctors and bronchoscopy assistant. That's very important to protect the doctors and the nurses. Consideration of the National Health Authority guidelines for the procedure of put on and take off the PPE, and for flexible bronchoscopy, transnasal assist is preferred with the additional use of Scott box and nozzle protector for the patients. You can see there are a procedure of the how to take off the PPE when we finish the examination. That means we must take off our gloves, our gowns one by one. That's very each work costs are about 10 or 20 minutes. If we must do that, if the rigid we must replace the rigid bronchoscopy with a jet ventilation, because the jet ventilation can reduce some micro dropped error. So we must reject. We replace the jet ventilation to closed ventilation system. If rigid bronchoscopy is unavoidable, then conventional ventilation and reducing of the air leakage. For the positive we must know there are abstract indications of this kind of patient. Just only for the diagnosis reason and the therapy reason. Diagnosis reason just only if the patient have a lot of pharyngeal smell is negative twice and clinically we think they are still is a COVID-19 patient, so we can give them a bronchoscopy test and examination get some buff in the in lung and do the confirm the diagnosis. And the other diagnosis and another diagnosis is considering that would significantly change the clinical management. Just only in these two conditions, we will do the diagnosis procedure. And for the therapeutic reason is just only one reason is that is an urgent life-saving intervention is necessary. That means hemostasis or higher or central airway stenosis or foreign body aspiration that is necessary. This is a list for the how to do the procedure before the examination. You can say that we got indication indication and benefits. That means sequencing and management and radiological reason or also commercial over-infection or hemoptysis or potential risk that it can get a respiratory detection or staph contamination. This is the procedure we can do, how to do a checklist. We can find the checklist in our article. That means our checklist too. You can see the patient in our article. This is my patient. This is my patient. But this is a confirmed patient, 66 years old male patient, and admission to our hospital with cough and fever for 10 days. And he got COPD and hypertension. And the patient was intubated and ventilated on March 15, and following the prosecutive hypoxemia and respiratory failure, despite high flow and VV ECMO was instituted on the day 2, and then on the day 4, we found that in the right lower lobe, we can find here changed. So we gave them a bronchoscopy scope and gave them a BOL in the right lower lobe. And we can find the second day, the second day we can find that right lobe open again. And we found a large quantity of mucus plug and cleared. You can see here, we will do the, for this patient, we will do the bronchoscopy for the, you can see we were wearing a mask, cap, and gums, and glass, and gloves. You can see here. There are single-use bronchoscopy here. This patient got ECMO at the same time. And after 11 days of ECMO, 11 days, we take off the ECMO. And after one month after the intubation, we take off the ventilator. And now the patient go back home. We can check here. So for COVID-19 patient has trachea and broncho. You can see there's most of them. There's a low sputum in the trachea and the broncho, but in the left lower lobe we give them an BAL. You can see here, left lower lobe. We reach the left lower lobe. Okay. We give them a BAL. You can see a plug. You can sputum plug here, just like this. Okay. So we give them a bronchoscope procedure that we must reduce when we do the procedure. We must reduce the air procedure. If you have a WHO sensitive checklist, we will do the procedure with the checklist to minimize the risk for the patient with intubation and mechanical ventilation. FiO2 should be adjusted to 100% during bronchoscopy. You can see here there is another patient with bronchoscopy. We can see the doctors give cups, a glass, a mask. A mask in the inner mask is FFP2 mask and a surgical mask and gowns and gloves and single-use bronchoscopy. This in China. Sometimes we use positive air, positive pressure system. When we do the procedure, we must adjust the ventilator to VCV and pressure limited mode, and give them maintain the SpO2 is more than 20 and more than 92%. For the patient on ECMO, anticoagulation should have been stopped a few hours before the procedure. But if you just do suction or BL, I don't think you need to stop the anticoagulation. But if you want to do a biopsy, you must stop the anticoagulation for a few hours. And PRT should be more than 50, and 50. And specimens should be stored and processed according to the biosafety requirement. A negative pressure shoot with at least 10 cycles per hour exchange is performed for the procedure if possible. But we don't have that condition. You especially in Wuhan, we don't have that. A review of the patient and the physiological parameter as well as the ventilator setting are advised. A chest radiography should be ordered to exclude pneumothorax. Atomized disposal single-use bronchoscopy can be used if timely and validated. Reprocessing of the bronchoscopy is not ensured. So this is our authors of the article. Thank you.
Yes, thank you very much, Prof. Ming Lu, for the excellent presentation. As we know that bronchoscopy is an aerosol generating procedure, but the usage is still needed for many patients. So the presentation could have many clinicians and also help patients who still need to undergo such procedure. Next, we'll proceed to our fourth presentation from Dr. Melvin Tay. From Dr. Melvin Tay from Singapore. He is the consultant at the Department of Respiratory and Critical Care Medicine, Singapore General Hospital, and also the Director of Interventional Pulmonology, founding member of the SGH Filipinos ECMO team. Dr. Melvin Tay Chi Kyung, your time is 20 minutes.
Okay, a very good evening to everyone. Thank you, first of all, to the organizing committee for this very kind invitation. So I've been tasked to share some insights about the management of critically ill COVID-19 patients, and it has been named as the price of oxygen. Anyway, happy birthday, Respina, 20th birthday. So my name is Melvin, and I'm the Director of Interventional Pulmonology and ECMO physician at the Singapore General Hospital. And today, I'll be sharing with you a few things. I'm hoping that this talk would be relevant to those of you who take care of severely ill or critically ill COVID-19 patients. I've broken down the presentation into 3 parts. So first, I'll be talking about definitions and common clinical features of these patients. And second, I'll move on to the principles of management, and I'll be focusing a lot more on respiratory failure and some on hemodynamic. And finally, I'll finish up with some new knowledge about the therapeutics in the COVID-19. So let's begin. The definition, there is no universal definition, okay? So, but the WHO China Joint Commission, which actually evaluated more than 50,000 patients, the definition was as critical was defined by respiratory failure, shock, or multi-organ dysfunction or failure, and severe meant either the patient fulfilled one of these criteria, which is dyspnea, tachypnea of more than 30 breaths per minute, a low SATs of 93% and below, a PF ratio of less than 300, and a more than 50% increase in lung infiltrates within 24 to 48 hours. However, there are a lot of other studies, and the severity is actually based on the need for ICU admission or mechanical ventilation. So how do patients with critically ill COVID-19 patients present? So not surprisingly, they present, most of them, the majority present with acute hypoxemic respiratory failure, and that constitutes about 70%. And about 30% would manifest with some form of shock or myocardial dysfunction, which is more like hemodynamics. And about 30% of them, up to 30%, would also develop some acute kidney injury. So moving on, we'll talk about the principles of management. So acute hypoxic respiratory failure, as I've mentioned earlier, it constitutes the majority of presentation in this group of patients. So I've broken down the principle of management in respiratory failure into 4 parts. Number 1, it would be what should we target the SpO2 to be? 2, what is the oxygen therapy device strategy? 3, close monitoring for respiratory status decline, and finally, mechanical ventilation strategy. So let's take a look. So all of these suggestions and recommendations are sort of summarized from the Surviving Sepsis campaign, which has been published with in special regard to coronavirus disease 2019. And as you can see, if you see a green smiley emoticon, that means it's a recommendation, and it's based on either best practice or at most moderate quality evidence. Unfortunately, we do not have very good, high quality evidence to back up all these recommendations. And if you see this cautioned triangular sign, it means that it's just a suggestion and it is based on low quality evidence. It's for ease of interpretation. So number 1, what should we target the SpO2 to be in COVID-19 patients who are hypoxic? So the recommendation is that we should not start oxygen therapy unless the SpO2 is below 90. And we also do not want to overcorrect the oxygenation of the patients, and that's why we say that the recommendation is that the patients should not have an SpO2 of more than 96. And as you can see, there is also a caution sign. So which means that it is a suggestion that you could start oxygen therapy if the SpO2 is less than 92, but it is recommended that you only start if the patient is more hypoxemic, which means that the patient has got an SpO2 on ambient air of less than 90. Moving on, we'll talk about, so what's the oxygen therapy device strategy that we should adopt? This is not a recommendation, but it's just a suggestion. So we should start with a conventional oxygen therapy first, which means nasal mask, intranasal oxygen, whatever you have, and keep in view high flow nasal cannula. And nasal cannula is preferred to non-invasive ventilation. But like I mentioned earlier, this is all based on very low quality evidence. But what is good practice is that regardless of the kind of oxygen therapy that you are giving to the patient, we should watch them like a hawk for respiratory status deterioration, which can happen very rapidly, as with most respiratory illnesses. So this is quite a busy diagram, but it's actually a very nice infographic also by the Surviving Sepsis Campaign people. It summarizes the recommendations on the initial management of hypoxic COVID-19 patients. So first of all, the first question that we should be asking ourselves is the patient, does the patient need endotracheal intubation immediately, urgently? If the answer is no, then we'll start the patient on supplemental oxygen, and after which we'll be observing the patient to see if he or she is tolerating it well. If he or she is, then we'll just monitor closely for worsening. And what if the patient does not tolerate supplemental oxygen well? For example, the patient you have put on like 4 to 6 liters of INO2, and as we all know, it can get quite uncomfortable with the high flows via the nasal cannulas, the conventional ones, and therefore you can consider HFNC. And as with conventional oxygen therapy, we should also be monitoring the patient very closely for worsening, because the drawback of this approach is that if we were to delay intubation, the patients may end up having a higher mortality or less favorable outcome. And in my opinion, I put a cross there, as you can see at the bottom of the slide, because I do not think, if the patient has already failed HFNC, I don't think, we should even consider non-invasive ventilation, but that is just my personal opinion. So there has been a lot of literature that is emerging on awake-prone positioning. So in SGH, in Singapore General Hospital ICU, we have a protocol. So patients who are suitable, we would put them on awake-prone positioning and HFNC together. So the inclusion criteria are as below, and I'd like to highlight this very important point, which is the second point, the inclusion criterion, which is that the patient must have considerable bilateral opacities on chest radiograph, which is compatible with the degree of hypoxemia. So this is a point I think I'll elaborate further down my slides. So the patient is made to prone while awake. So we'll, as you can see from the diagram, the patient is prone for about 30 minutes, lying flat down, and after which the patient will be lying on the, either the left or lateral, left or right side. And the third position will be sitting up about 30 to 60 degrees, and finally lying on the contralateral side again before coming back to prone. So as you can see, we have a sort of like photographs to sort of demonstrate to the patient what they should do. And the maneuver will subject suitable patients to 4 sessions each, 4 sessions daily, 2 hours each of prone awake prone positioning. And the decision for termination criteria for termination of awake prone positioning and HFNC would depend on the ROX index as well as a clinical judgment of the managing physician. So I'd like to emphasize a very important point. A lot of interest has been gathered to use awake prone positioning with an HFNC. And even in our national center, they have recently published a letter to ERJ saying that perhaps awake prone positioning supplemented by some form of oxygen therapy would reduce the rate for intubation and maybe reduce the ICU utility burden. Of course, I feel that it's too early a point to make, and despite there are subsequent studies that have come out, I would like to stress the importance that the patient selection in awake prone positioning or continuing some form of oxygen therapy for COVID-19 pneumonia, it's very, very important. And why do I say that? Because it's all about trajectory. So in this letter that my colleagues and I wrote to ERJ, so to the editors, we have highlighted that in our group, in our small case series, some patients, depending, we have some signs to say that the trajectory is likely to be bad, and versus a trajectory is likely to be stable, right? So it is not for everybody, and the most important thing is that in patients, the most important thing is that we need to continuously monitor them for signs of deterioration. So as you can see in this sort of summary statement, it is increasingly recognized to manifest phenotypic diversity in clinical presentation, severity, and trajectory. So we are in the midst of preparing a manuscript for one of for our patients in the SGH that we have seen, and we are offering some clinical science and history, clinical history, together with some laboratory tests that are simple and can be used in resource limited settings to predict trajectory, the prognosis of the trajectory. Okay, and lastly, finally, we'll move on to the mechanical ventilation strategy of how to manage these patients if they were to be intubated. So the story of mechanical ventilation in COVID-19, it's a bit convoluted and it's highly controversial, and it began with Professor Gattinoni from Italy writing a letter to the editor in the Blue Journal and talking about atypical ARDS in COVID-19 pneumonia, saying that it is sort of different from the usual, ARDS that we have been seeing, whether it's with a viral illness or bacterial pneumonias. And he and his, of course, co-workers or friends postulated that there were two types of COVID-19 pneumonias. So there was a type L or type 1 versus a type H. So L stands for low. So in type L, COVID-19 ARDS, these patients have low elastance, which means that the compliance is pretty good because compliance is the reciprocal of elastance, and they have a low VQ ratio, which is attributed to this loss of hypoxic vasoconstriction. And because of that, these patients do not respond very well to recruitability, because there is, the pathophysiology centers around the loss of hypoxic vasoconstriction. And in contrast, you have type H, which means high elastance because of interstitial and alveolar edema. And then you have a high right to left shunt, especially in the dependent region. And these patients have high lung recruitability. Basically, type H just means your run-of-the-mill severe ARDS. So this spawned a series of letters and editorials to multiple high impact journals, and then talking about phenotypes, in ICM as well as critical care, until Dr. Bos from Amsterdam wrote an editorial not too long ago to ERJ talking about the perils of premature phenotyping in COVID-19, a call for caution. And this sparked off and sort of like a war. So quoting him and his colleagues, he said, by prematurely phenotyping patients, we risk causing considerable harm and generating more static than signal. It's quite a scathing sentence, I guess, and of course, it's sort of sparked a fight back from Gattinoni and JJ Marini, and this is the first time that I've saying that there's so much emotions in academic letters, and they started off the response by saying that we read the editorial by Bos et al. With a mixture of interest, irritation, and serious concern. Regardless, I think it is like a fight between David and the Goliath, and of course, Gattinoni subsequently garnered a lot of letters that supported him and sort of criticized Bos in ERJ. But the truth is, I do not think that Bos was wrong or is wrong, because I guess he could have just toned down on his letter, but I think there was a lot of academic value in what he said. Regardless, there have been a lot of other phenotyping being done, clinical phenotypes, and then using clusters. Regardless. So what, as with all this emerging sort of even conflicting like literature. So what did we do at SGH? So I was one of the first few attendings or consultants that was tasked to run the SGH MICU for COVID-19. So unlike what we have, Professor Gattinoni and the rest have sort of postulated, we didn't really see somewhat the type L phenotype. In fact, we thought that we actually saw that these patients who had near normal compliance were actually very recruitable. And we wrote a letter to the critical care medicine, and it was a pretty, it was a letter that was concentrated quite a bit on physiology, respiratory physiology, and we were very glad that finally someone understood what we were saying. Anyway, just to make it very simply for you, we think that, in the beginning, COVID-19, I do not think it's a different disease itself. It starts off as a viral pneumonia. It's the same distal bronchiolitis, maybe early alveolitis. And what happens is that with bronchiolitis, there is always early collapse of the closure of the airways, right? And therefore, in these cases, whereby, and that's why when you have bronchiolitis, the chest radiograph, right, may be very nondescript, and because usually bronchiolitis will occur concurrently with some form of alveolitis, and that's why you see ground glass opacities on CT thorax. And why it responds to PEEP, our postulation is that because with the bronchiolitis, there is the closing capacity is disease. The disease closing capacity is going to be higher. And therefore, what we are doing by giving PEEP is to just increase, right, the functional or the inexpiratory lung volumes, right, to be higher as well, so that, it can sort of go beyond the closing capacity. And therefore, this results in recruitability of the collapsed airways and alveoli.
Dr. Melvin, your time is 1 more minute.
Yep. Oh, sure. Okay. And then we have reported it in a few patients in our letter. So my own learning points on mechanical ventilation in COVID-19 is that COVID-19 is, ARDS is not a new disease, whether it's in terms of lung mechanics and many other things, and it exhibits phenotypic diversity and lies on the spectrum. And the final endpoint is just the same, run-of-the-mill severe ARDS. And however, we must pay attention to the disease trajectory because it's very crucial. And is there any way we can predict the development of ARDS or to arrest it? And we have got some research work ongoing in progress. And mechanical ventilation strategy must be personalized. And otherwise, for severe ARDS management, it remains the same for COVID-19. As I'm running out of time, I think I will stop here. And then if given an opportunity, I'll be able to share my slides with the remaining information with everybody. Thank you very much.
Thank you, Dr. Melvin. The presentation is very interesting, so perhaps we could discuss more about it in discussion session. Next is our last speaker, Dr. Francisco Diaz from Washington, D.C. He is the medical director and deputy chief medical examiner in Washington, D.C. and also the advisor for International Criminal Investigate Training Assistance Program at U.S. Department of Justice. Dr. Francisco Diaz, your time is 20 minutes.
Thank you very much. I'm trying to share the screen. Let's see if I'm able to. Excellent. Thank you very much. And good morning from Washington, D.C. I am the medical director for the Office of the Medical Examiner. So we're going to talk about death during the COVID pandemic. It is worth of note that medical examiners and coroners in the United States, our jurisdiction are the non-natural death, such as suicide, homicide, motor vehicular collision, drug-related death, and sudden, unexplained, and unexpected death. Therefore, death due to COVID-19 are not, by definition, the jurisdiction of the medical examiner. Here in Washington, we decided to take over the certification process of COVID death for several reasons that I'm going to tell you about. Washington, D.C. is a unique city in the United States because it's the seat of the capital, the capital of the federal government. And as such, a lot of the land belongs to the federal government and a lot of the land belongs to the city of Washington. It's a population rather small, it's only 700,000 people. A lot of the people are bureaucrats that work during the day in Washington, D.C. and then reside in Virginia or Maryland.
Dr. Diaz, I'm sorry, we still cannot see your presentation.
Okay, can you see it? Let me see. Resume share. How about now? Can you see it?
Not yet, doctor.
Okay. How about now? Can you see it now?
Yes.
Excellent. So as I was saying, we made the decision of take care of the COVID cases because we realized the epidemic or the pandemic came late to Washington, D.C. as compared to other cities like New York City. And we saw that the hospital system was being overwhelmed. Where do they keep the dead bodies? And we decided to take jurisdiction, certify all the cases, as well as to offer storage, as well as offer free cremation. For that reason, we established a disaster morgue. To this day, approximately 190,000 people have died in the United States. This slide shows you, even though it's a little bit dated, it's from June, shows you the difference in the peak of the epidemic on the different states. In April, Montana, and by June, Alabama. And some, we are in September, Florida, Texas, they're having their peak right now. So as in any big country, it is not homogeneous the way the epidemic behaved or the peak of the epidemic. In Washington, D.C., we have 775 deaths so far, of which 615 were residents of the city of Washington. Some people, the other 160, were not residents of Washington, but died in our hospitals. Our morgue has a capacity for 250 decedents, 11 autopsy tables. However, we do have an advantage, which is we have 2 autopsy rooms, which are biosafety level 3. And those are very good for performing infectious autopsies such as meningitis, and in this case, COVID-19. Again, we do not routinely perform autopsies on COVID-19 because at the end of the day, those are natural death. We have performed several for scientific interest, and because for several reasons, they fall into our jurisdiction, either because they died and they were doing drugs, some have been homicides, and so on and so forth. We have to increase our capacity, and for that, we requested refrigerated trucks, and we proceeded, as I said, to create an disaster morgue with a command center for releasing and receiving the bodies. And the process went smooth. We closed it down momentarily, and hopefully we are not going to have a second wave. Briefly, because the time is upon us, I just wanted to show you the peak of the epidemic in Washington, D.C. You can see the number of deaths per week, which the highest was between the weeks of April the 12th and May the 3rd. After that, you can see how it's been very, very decreased, the number of deaths that happened during a week. For example, today, which is Saturday, there are no COVID cases reported in Washington. This is a more busy slide, but you can see that's day by day, starting in March. But you can see again, at the height of the epidemic, we have approximately 20 deaths every day here in the city. And this is important because this ties up with what we were talking before, the other panelists, about what are the comorbidities with this type of patients. And in the United States, we have, our population suffers from significant comorbidities. Morbid obesity is an epidemic in the United States. And because of that, we have an increase in diabetes, as well as an increase in patients with high blood pressure. Please take a look and see that 70%, 7 out of 10 people that have died of COVID-19, also at the same time, they have hypertension, and nearly half have diabetes. You can see the age breakdown of the decedents, where nearly half of the patients are 75 years or more. And approximately 3 out of 4 are 65 or more. So for Washington, it is an elderly population with hypertension and diabetes. That's the classic patient that comes to us. We have a vulnerable population. In our jail system, only 1 death has been reported. However, we have a significant number of deaths in nursing home, hospice, assisted living, and so on and so forth. Not as many people that are homeless, but we have a few. And this is published every day by the City of Washington Department of Health, and that's how they gauge the resource utilization. You can see on the bottom the total adult ventilator use COVID and non-COVID. So that's a way to gauge how many ventilators the hospital system in the city has versus the one that's been used. And the total number of patients in the upper portion of the slide that have COVID as compared to patients with non-COVID. It is also very important that we have established a nasopharyngeal swab in decedents. And I was asked by our Department of Public Health, well, we're not validated. And I said, we're going to do it anyway, because guess what? They were alive an hour before they were dead. So let's see what happens. And we've been relatively successful. We will publish a peer review article about our experience in conjunction with the University of Michigan, which has also a very robust post-mortem nasopharyngeal swab program, about our experience. Anecdotally, I can tell you that, in my opinion, if the person has been dead for 24 hours or more, it's going to come negative. We do have in our office a digital radiology equipment, which is a great advance in forensic medicine in the United States, because that takes only 12 seconds to perform. And it doesn't have a high resolution. We are not radiologists, but it's a tool that helps us in our diagnosis. It goes without saying that in an environment such as this imaging technology is used for locating bullets and other objects, as well as fractures in the extremities and what have you. However, we can use it to see if a decedent, a person is found dead on the street. The first thing we do is we take an X-ray, and then you can see, without being a radiologist, you can see the opacity in the lungs, and you can see that the person had a pacemaker. That's a patient at risk. You can see another one with an increase in the cardiac silhouette, another one where the chest is basically obliterated. So it's not diagnostic, but it provides us with an idea what the patient may have. Up to date, we have swabbed 184 cases, 38 of which have become positive. We are confronted not only the consequences of this epidemic, but also collateral damage, as I call it. A lot of people that otherwise would have sought medical attention are dying at home because they don't want to go to healthcare facilities with the fear that they will be contaminated. And therefore, they're dying at home. And some have COVID, some don't. Some have cardiovascular disease, kidney disease, and what have you, but they're dying at home. Therefore, it becomes our jurisdiction. But it's significant that people without any history, because of that swabbing program, approximately 1 out of 5 have come back positive. And it's basically the same breakdown as I told you before in terms of the comorbidities. Hypertension is very prevalent in this type of patients as well as diabetes and some with asthma. And let's go to the part that you are interested. Are we doing COVID autopsies? And the answer is we are doing some. And the findings are interesting. And one of the previous panelists basically stated that 20 to 30% have myocardial damage. And that's a very interesting finding, because it's not only the classic acute respiratory distress syndrome with the membrane, hyaline membrane formation. We are seeing real cardiovascular issues. And let me show you, this is very non-specific, but what we see is on autopsy, congested, boggy inconsistency in the lungs. They are usually twice as heavy and compacted as in a regular autopsy of somebody who died of other causes. You can see here a comparison how those lungs are very compacted on autopsy. Usually people who died of other causes, they have more spongy, if the term applies, lungs. This is the cut surface, and you can see how compacted they are. It doesn't retain the form of a sponge anymore. It's not diagnostic, but because you can see it in other conditions, such as massive pulmonary edema, but this is what you see in this type of death. This is the classic histology with the membrane formation in the alveoli, and you can see how the alveoli space is occupied by cells. Therefore, there is not enough space for oxygen exchange. This is another view where you can see that the alveolar space is basically non-existent. It's also been talked about the microthrombi formation, which we have seen in several cases as well, in the lungs as well as in the kidneys. And it is signified by the arrows. This is a slide that shows you the alveolar space occupied by acute inflammatory cells. This is a classic view of a patient with bacterial pneumonia. Approximately 40% of the autopsies we have performed, instead of having acute respiratory distress syndrome, they have bacterial pneumonia, similar to patients with the viral flu, which is the patient starts with a viral pneumonia, and then it's superseded by a bacterial infection. This is a classic example of a bacterial pneumonia where all the alveolar space is occupied by neutrophils. And this is another example of the alveolar response to in patients with COVID-19 with some hyaline membrane formation. And this is immunohistochemistry that we performed in the first autopsy that we did, just to confirm that it was COVID-19. And to finalize, I just want to highlight, because it's interesting to me, the cardiovascular findings. What you are seeing there is the pericardium, and the decedent had a significant pericardial effusion. And that is not uncommon on autopsies with COVID-19. You can see that they have pericardial effusion, sometimes just 40, 50 cubic centimeters, but sometimes more. This is very frequent. It is also, as the other panelist was talking about, the myocardial damage. What you're seeing there on your screen is a section of the myocardium, and what you're seeing on the arrows is basically what we call in pathology contraction band necrosis. So in a patient, in the absence of coronary artery disease, they're having ischemic episodes. And that's also a significant finding. We have found a handful of patients with full-blown myocarditis. And you see that discoloration on the cut section of the heart, and it has a reddish type of discoloration. It's not diagnostic of myocarditis. What is diagnostic of myocarditis is what you see on the right of your screen, which is the myocardium being infiltrated by chronic inflammatory cells, chronic lymphocytes. And we've seen that in several patients. This is another example that you can see how the myocardium also has in the left ventricular aspect a sort of reddish discoloration, and the patient also had myocarditis. So in summary, what we have seen the classic findings of acute respiratory distress syndrome. We have seen cardiovascular changes such as myocarditis, pericardial effusion, myocardial ischemia, and because of the time limit, I didn't include changes in the kidneys, but they are significant, as mentioned before, in terms of presence of microthrombi in the kidneys. So it is it's an all-encompassing disease in a lot of patients. It affects the pulmonary system, the cardiovascular system, as well as the kidneys. We haven't had found changes in the brain, but they have been described in autopsy series coming out of Louisiana as well as Oklahoma. We had submitted brain for neuropathologic studies, and then we plan to include those in further conferences. You will have access to all the slides, but if you have any questions aside from this, you can email me anytime and I'll be happy to answer your question. And with that, I do thank you, RESPINA, for inviting me and for taking into account also findings in dead people, which I think is very important during this pandemic. Thank you very much.
Thank you very much for the presentation, Dr. Diaz. It's very interesting since we haven't performed a lot of autopsies and the data about autopsies is limited. And now, before we're going to proceed to discussion session, I would like to invite our overseas moderator, Dr. Shogi Sham, because this is the 22nd anniversary of the RESPINA Society, which was born at 11 September 1998, and also in conjunction with the official day of RESPINA establishment and July 16, 1999. Dr. Shogi Sham is our moderator. He's a pulmonologist, and he's also the second RESPINA Global Sharing Scientific Committee. So he's the one behind all of this wonderful webinar. Dr. Shogi, time is yours.
Thank you, Dr. Dian. Dear colleagues, allow me to tell you a short brief regarding RESPINA. It was started in 11 September 1998 when 5 pulmonologists were sat together to discuss and put their mind for Indonesia. The respiratory care means that it's not all about the pulmonologists with their knowledge. It's including multidisciplinaries among physicians who have a same interest and concern in respiratory care. And now, RESPINA is one of the large group meetings with 13 societies involved in Indonesia. As we are aware, the pandemic situation has pushed us down and made us lose someone that we love and care. Our colleagues, friends, and family. And we are feeling pain and suffered. Well, this is not the end of the world. We are human and we should move on in many ways, whatever way it is. As the respiratory care has becoming a trending topic in over the world, this re-emerging disease makes us, as the physician, healthcare workers, and scientists, to work together, fight to win the battle. RESPINA will keep its existence and keep spreading valuable information in respiratory care corridors. Now it's been 22 years since the first movement, and they will continue to spread their wings and try to reach the highest level. To you all, the RESPINA founders, happy anniversary and wish you all the best in the future.
Good morning, everybody. My name is Cesare Gregoretti. I am coming from Palermo, Italy, where I'm running an intensive care unit. So I have been attending RESPINA for many, many years, since 2006. It is my pleasure to have the possibility to send this message, where I want to state and I want to remark that RESPINA was born to share knowledge in medicine and knowledge to have the possibility to cure better our patients. And it is in this time, it is a tough time where we are obliged to cure right now one of the worst pandemic in the world since many years ago. And RESPINA did its best in order to try to train physicians to let them understand physicians how to cure this disease. So I hope that this mission will found the people ready to do their best in this pandemic. Thank you very much.
Hello, this is Martin Tobin in Chicago, United States, sending best wishes to physicians and allied health personnel at the time of RESPINA's anniversary. For those of you who have lost colleagues or family members, I extend condolences. Given the lack of effective pharmacological agents, the most important tool in coping with COVID-19 is scientific knowledge. For more than 20 years, the dominant mission of RESPINA has been the dissemination of scientific knowledge to colleagues throughout the Indonesian archipelago. I have published several articles, each providing practical advice on different challenges, which can be downloaded by going to PubMed or another search engine and typing in Martin Tobin COVID-19. Making decisions based on scientific knowledge, together with empathy towards our fellow human beings, is now more important than ever in our work as physicians. Thank you.
Mabuhay from the Philippines. Warm greetings to my RESPINA family, and congratulations to the organizers and faculty of this second Global Sharing virtual conference on COVID-19. You know, in 2001, I gave my first talk for RESPINA. It was on flu vaccination. Today, with an unanticipated pandemic, the scientific community is hoping for a vaccine that hopes to control the spread of this disease that has claimed millions of lives. Today, it is my turn to learn. We have had painful experiences in treating this COVID-19. But we know more and hoping that we will learn more today. This is the strength of RESPINA, sharing and caring. Good day.
COVID-19 has impacted everyone, with respiratory clinicians in the front line of care and people living with respiratory disease amongst the most severely affected. But at the same time, a spotlight has been shone on respiratory medicine, and respiratory medicine is on the world stage for the first time. So it's never been more important to identify those living with respiratory disease, to ensure that treatment is optimized, and to train clinicians expert in respiratory medicine. Thus, whilst we grieve for those that we've lost, by working together, we do have an opportunity, and the time for that is now, to transform the future care of respiratory disease. We must seize this opportunity, and I wish colleagues in RESPINA every success in achieving that. Congratulations on your anniversary, and very best wishes to you from London.
Greetings from Amanda Piper, Royal Prince Alfred Hospital, Sydney. Just over 12 months ago, I was enjoying the gracious and warm hospitality that RESPINA is renowned for as I attended the 2019 meeting in Jakarta. During that time, we had the opportunity to talk about respiratory medicine in disaster times, little realizing that we would be shortly living through a worldwide respiratory disaster of our own. I've been deeply distressed to hear of the terrible toll this virus has had on you in Indonesia. I and my countrymen offer our prayers and condolences for all of you who have lost family, friends and colleagues. We wish you strength and resilience as you battle this tiny but terrible foe. And I look forward to a time when once again our borders are open, we can meet up again, renew friendships and share ideas regarding respiratory medicine.
Dear colleagues, this is Dr. Reddy from the United States. It gives me a great pleasure and honor to address you. I just want to let you know that in the year 1999, nearly 20 years ago, I was invited by Dr. Rasmin to attend a RESPINA meeting. And from that time onwards, I have been a part of RESPINA, which I consider as a great privilege. Unfortunately, COVID-19 has taken our lives, but we as a doctor has an obligation to take care of our patients and our people. In order to make sure that we can do this, we must ensure that the people will follow few simple steps. That includes hand washing, facial coverage, and maintaining a distance of 6 feet. It is true that vaccine will come, but the question is when and who will get it. No one knows the answer. In the meantime, as doctors, we should do whatever is possible to keep our patients safe. Wish you all the best.
Yes, thank you very much, Dr. Shogi Xiang from London, UK. Now we're going to proceed to our discussion section. We have already here with us 4 panelists. Prof. Feng Ming Luo is unable to attend the discussion because he has an urgent need. So we already have some questions, and some of it has been answered live. Some of it has been answered from the Q&A section, and we will discuss another question, some other question. The first one is to Dr. Dewi Anita, clinical pathologist. There are a lot of questions to Dr. Dewi, especially. We want to ask, people want to know about the usage of IgG and RT-PCR. Do we need to do both, or is the usage is interchangeably?
Thank you for the question. For diagnosing COVID-19, we still use the WHO recommendation that we using RT-PCR to make a confirmed diagnosis of COVID-19. But the serology testing we can use for complement to accompany the RT-PCR testing. We cannot use serology testing to make a diagnosis for COVID-19.
Okay, thank you very much. And another question, which one is better, the nasopharyngeal swab or saliva? Because saliva is, some of the research has been updating about saliva usage as a diagnostic.
Based on the study data, I read that the nasopharyngeal swab has sensitivity of 60 to 70%, but the oropharyngeal swab or from saliva is the sensitivity only 30%. Maybe they are using a different method, not RT-PCR.
Okay, and other question, how do we know if the patient is not infectious anymore? Because some of the patients still have RT-PCR positive in many weeks, perhaps 2 or 3 weeks, and it's still been a question for everyone, how to discharge patient, when to do another swab test, because it's still cost effective.
Okay, thank you, Doc. Actually, we have already released the recommendation for discharging patient. They consist of 2 different ways to discharging patient. One is based on symptoms. If based on symptoms, it means that for asymptomatic patient, then isolation is only 10 days without the need of RT-PCR testing. But for patient with symptoms, then we need isolation 10 days plus 3 days post free symptoms. Free symptoms. So, but if we want to use the RT-PCR testing based discharge by depend on based on testing, then we need 2 times RT-PCR negative. But why people sometimes still have positive for RT-PCR test after months? So the RT-PCR is detecting genetic materials. So sometimes when the virus is already fragmented, we still can detect it by RT-PCR. Based on several studies that virus is still virulent in nasopharyngeal only 15 days. So actually, after 15 days, even that we still found the RT-PCR positive, then the people not infected anymore.
How about the usage of the CT value, doctor?
The CT value, okay. CT value is how many times the PCR equipment have to amplificate the virus to become so we can detect the virus. So the city value really depend on the pre-analytic process of the laboratory. If when we take samples from the nasopharyngeal swab and then we only get a small amount of virus, then the city value will be high. But if we take samples from the nasopharyngeal swab and we have a lot of virus, and then the city value will low. So the city value really depend on the pre-analytic process, so when we swab the patient, and then also depend on the equipment that we use. Some equipment can detect city value more than 30, but some equipment only detect city value less than 30. So we cannot really depend on city value.
So basically, clinical assessment is still needed.
Yeah, clinical assessment is more important than the than the test.
Okay. Also, there's question about IgG, CLIA, and also antigen test. What do you think about this method?
Okay, so serology test, instrument-based serology testing has many kind of method. The one that we use in Persahabatan Hospital is CMIA, chemiluminescence immunoassay. There is another equipment use method CLIA, chemiluminescent electric assay, and the rapid test that we always use is lateral flow method. So there is a lot of method to detect serology, actually, antibody, actually. So what do we need to do is for the laboratory is to do the method validation. We have to do how is the CV of the test, how is the sensitivity, how is the specificity to compare so many testing method. For antigen testing, there is still some research for antigen testing, but they say that antigen testing is good for detecting and good and fast, of course, for detecting antigen for patient with symptoms less than 7 days.
Okay, thank you. I would like to also to ask Dr. Melvin and Dr. Diaz, how do you use IgG or swab test in your country?
For us, the diagnosis is via the nasopharyngeal swab. We have already a government-linked agency that's producing saliva test kits. But like what our previous speaker has said, yeah, I think a lot of it still needs to be further evaluation. For serology, we don't routinely do it. And for cost reasons, because we have had a spike of cases amongst the dormitories, I think a lot of time we just sort of like keep them isolated in either community facilities or some isolation facilities for 14 days. And after which, you know, we just sort of assume that they should not be infectious already in the absence of symptoms. Yeah, because otherwise, you can imagine in the initial days of the pandemic, we were swabbing patients almost every other day, you know, and then of course the swabs kept coming up positive, and there was a patient who had positive swabs for like close to 2 months, and then you know, but that was really in the beginning when nobody knew any better. Yeah.
Dr. Diaz, any comments for the diagnostic test?
Yes, and I will answer in two fronts. One, the city of Washington has a program for their citizens. So every citizen is entitled to a nasopharyngeal swab if they can prove they reside in the city. And there are several locations for that. For post-mortem, and I think the question was posed in the chat, when do I think is no longer the virus viable? And I can tell you, after the temperature started to rise here in Washington, this is a city or a location which we have 4 seasons, but the late spring and the summer are hot and humid. As soon as we started to get increase in temperature, and we have a lot of decedents that are found at home, basically in the early stages of decomposition. 90% of them has tested negative. I have some, 2 or 3, that even in the with obvious signs of decomposition, they have come back positive. The question is, how long does the virus live after death? In my opinion, in the perfect conditions, 24 hours, because that's been my experience. And I would like to validate that experience. But you have to take into account the variables as well. You know, we bring somebody from the house or from the street, and we put it in refrigeration immediately. And then we do the swabs. And so it's not an exact science, the post-mortem swabbing, but it's been a great tool for us to determine patients that are at risk. And there is a correlation for us in terms of those positive cases with that quick digital imaging that we do in terms of pulmonary findings, even though we're not radiologists. So I would say 24 hours.
Okay, thank you, Dr. Diaz. Next questions, we still have a lot of questions here. To Dr. Melvin, a lot of question about intubation, how or when to intubate. Is it better if we wait and use the conventional oxygen therapy, or is it whether it's the early intubation is better? Which one, doctor?
I think this is a very difficult question. So I think nobody really has the answer. So incidentally, one of the speakers just now who congratulated RESPINA, Professor Tobin, so he wrote a letter to Blue Journal at the beginning when Katinoni was coming out with all these editorials. He said, you know, do not be in a rush to tube the patient, because I think there was a question on happy hypoxia. Patients who seem pretty well, but in his view, he said, you know, he personally, Professor Tobin, had been through an experiment, and then he said, you know, he was subjected to, you know, low sets. I think he had a set of like 80%, and he said he couldn't tell the difference between 80 and 90. And in his letter, I think he also wrote about how there was no good evidence that having a set of less than 70, or you know, of anything more than 75% actually led to some form of end organ damage. So to put it all into context, I would say that at the end of the day, unfortunately, you know, despite that we have so many kinds of monitoring equipment and everything, it takes a physician. It's a composite of, like as mentioned earlier, the patient's trajectory, clinical trajectory, and then of course clinical signs, right? Clinical signs and the degree of hypoxemia, which has to be taken into consideration of the patient's ability to sort of compensate and what do you call adapt, you know, accommodate, and so it's like I said, there is no fixed answer for this question, but just have to remember that on the other hand, right, we are worried that, you know, if we delay intubation, right, there's always a risk, as we have already seen in previous studies with HFNC and NIV, that if patients really need to be intubated in the end, then prolonging or, you know, delaying the intubation process may lead to worse outcomes. So that's why I would honestly say it's a very difficult decision to weigh the pros and the cons, right? At the end of the day, I think that's why at the end of the day, I feel that it's you have to take into consideration everything, including clinical history, parameters, radiology, and of course physiology. Yeah, but I don't have a you know, one size fits all answer to that.
Okay. How about the PEEP, doctor? Is there any optimal PEEP that should be used for this kind of patients?
Okay, so the mechanical ventilation strategy, of course, as sort of briefly mentioned earlier, it must be somewhat personalized, especially at least in our own cohort. We have noticed that patients with some form of radiology physiology mismatch, which means that, you know, the X-ray may be very nondescript and you have very profound hypoxemia. And these patients would have been sort of labeled as type L according to Gattinoni and et al. But we have proven, and at the same time, there's a lot of other supporting studies to say that the patients do respond to some form of positive and expiratory pressure. So at the end of the day, like I said, it has to be very sort of personalized and individualized, and it's not the worry, as Professor Tobin wrote in his letter, is that we sort of jump into an algorithm. It's like, oh, this is ARDS, this is atypical ARDS, and then we sort of pigeonhole patients into certain, profiles or phenotypes which may not be even true. And therein lies the potential consequences of it. But like I said, most of the time, these patients, at least in our practice, the ones with very profound hypoxemia, with a very non-yielding X-ray, actually a great percentage of them do respond to PEEP. Yeah, and that's why at the end of the day, there's no harm just trying to see whether the patient is recruitable or not on the mechanical ventilator. Yeah.
And how do we prevent the worsening of the happy hypoxia? Is it justifiable? Do you think it's a right thing to do for everyone to have pulse oximetry at home? Because a lot of people buying the pulse oximetry.
Okay, so I think this can be sort of, if we are going to do this as a community kind of thing, then it really depends on what the, maybe the organize or the committee thinks it's safe as a SPO2. But in my opinion, the hypoxemia alone is not enough to warrant, for example, intubation. So even tachypnea, as Tobin wrote in his letter, it's unusual. It's actually normal because in patients who are unwell, regardless of whether there's metabolic acidosis or not, a lot of them have tachypnea, but doesn't mean that the patient needs to be intubated. But we always say, oh, the patient is in respiratory distress. But what do we exactly mean by respiratory distress, right? So in his letter, he's also highlighted that respiratory distress is best assessed by the bedside, which is like, a very old school physical finding kind of thing. And it's actually using the accessory muscles of breathing, which is specific to, using the sternocleidomastoid mastoid. And that is why in our SGH protocol, we actually made a point to say that the patient must not be in any respiratory distress, and that means that the patient is not using, this accessory muscles of breathing. We actually made it a point to put it inside before we, have the patient on HFNC with a wake tone positioning. Yeah.
Okay. Another question about the dimer. How do we use the dimer as prognosis or therapy guidance?
Okay, so there have been so many studies that have been published, looking at trends of different laboratory parameters from CRPD, dimers, ferritins, interleukins, and what have you, TNF alpha. The thing is, it's common sense, I think, right? If all these inflammatory markers are high, it means it portends, a worse prognosis, right? In a way, but the issue is, but you have to serially measure it, right? And therein lies the problem because what if there's a discordance? Some if you measure everything, and then some goes up, some goes down. At the end of the day, and then what if some labs do not have the capability to measure things like interleukin-6, right, and other cytokines? So and that is the question that we are trying to address in a study that we have already been preparing for the manuscript. That's why I said to just by looking at certain parameters, right, which are like clinical, very simple things like fever, like how high the CRP, how high the fever, right, and onset of at the onset of oxygen dependence and the trajectory, and you know, a measure of all this, a composite kind of score derived from these simple parameters, right, and will be able to sort of predict with quite good accuracy which patients are going to end up being intubated, or rather, which patients are unlikely going to be intubated. And that is the question that is so important, because, you know, instead of, otherwise it's very dangerous, because we always say, oh yeah, we have HFNC, we have all this wake prone positioning, it's going to, we are going to use it on everybody. And, you know, we say, oh, because it's been proven that it would reduce our rates of intubation, right? And therefore you decrease our rate of ICU admissions, and of course the healthcare burden in general. Yeah, but I think we have to be very, very cautious on how we interpret the available data. And so far, the literature is that, you know, they have all this prognostic kind of, like, you know, patients who are old, patients who have comorbids, you know, kidney disease and blah blah, chronic lung disease, and, you know, and then of course how high the CRP. But it's all at it's all a time point, right? But it does not, all these things do not sort of like give you a clue on how the trajectory is going to be, unless you serially do it, which is not very, very useful. You get what I mean? Because that means that you have to incur costs, you have to, and then, like I said, availability of your labs to perform all this very specialized tests. Yeah, so I'm hoping that within the next less than the next month or so, we'll be able to get a letter out that you know, share of experience with all of you, that you know, sometimes using very simple data points, we can actually predict, you know, with quite good confidence that patients are not going to need intubation. Yeah, and the most important thing is hinges on a very important part in the history, which is what we found, and it's something very, very simple. Yeah.
Thank you. The question about how to do prone position, especially in intubated patients. Can we do it in intubated patients?
So yeah, of course, with like I said earlier, if it's going to be the typical run-of-the-mill ARDS, the management principles are the same. So you still use low tidal volume ventilation strategy, early paralysis and proning. So that has been routinely done, and it's good evidence, all proven with ARMA trial, the ProSiva trial, Accurasis trials, and all this are well proven that they work in the run-of-the-mill ARDS, whereby, you know, according to the definitions of Berlin criteria, and of course lung mechanics, they have like poor compliance, you know, stiff lungs kind of thing. So definitely, yeah. But what we are talking about is, you know, in these patients who are not intubated, so this is a wake-prone positioning, so it's somewhat different. Yeah, but like I said, regardless of whatever maneuvers that you do, whether it's awake-prone positioning or any fancy oxygen therapy device that may come up during this period of time, we never know, right? Everybody is trying to have like a goal, you know, trying to have a chance to be famous by coming up with something new. But regardless, the thing is, that point, which is like, I always think it's like an art already. It's like you have to decide like when the patient needs to be intubated to balance the risk of overzealous on intubating versus that must be weighed against the consequences of delayed intubation. And I don't, unfortunately, like I said, if you're going to ask, I suppose, yeah, very, very senior or very, very well-known, you know, respiratory or critical care physicians, I think nobody really has an answer to that, because everybody is different. Yeah. So that's why at the end of the day, which was one of the things that I wanted to highlight in my slides in my talk, but yeah, enough time, is that we have to critically appraise the current literature and then we have to believe that our findings. Sometimes it's like there's a lot of we tend to look to the apologies, Professor Diaz, but we tend to look to the West, right? And then we say, this literature comes up from the US, is it can be trusted. And then although unfortunately I think Professor Loh is not here, but I'm Chinese by heritage, and I was reading Chinese journals at the beginning of the pandemic, and by late January, early February, the Chinese journals were already saying that it was so infectious, and this was likely to have aerosolization, and that was the sort of the angle I took up with my hospital admin, and that say that we at that time already when we first started, it was N95, eye protection, and everything else. Yeah, but of course, there was some resistance because they were saying, but everybody is saying that it's droplet, right? And it was 7 weeks later when it was NEJM published by the scientific experiment performed by the Americans, and then they said, it can stay in the air for so long, and then everybody said, okay, now take aerosol precautions. But anyway, I digress. I'm sorry.
Thank you very much, Dr. Melvin. Next, we'll proceed to questions for Dr. Diaz. There's a lot of questions, especially about the findings in autopsy patient. What is the pathognomonic findings in patient died because of COVID? And can we use it to guide therapy?
Can you repeat the last portion, please?
Okay. What is the pathognomonic findings in patient died because of COVID, and what information can we use to guide therapy?
I will start with what Dr. Melvin said. One size doesn't fit all. And we have found a lot of variability pertaining to, in my opinion, to the number of days that the patient has been hospitalized. The longer they've been hospitalized, the more likely you will find added bacterial pneumonia. To me, as a forensic pathologist, the most significant finding is the concurrent findings in the lungs as well as in the cardiovascular system. And I think to me that is significant because I think, to use a boxing term, that's like a 1-2 punch. And I think that's something that has not been taken into account. The patients that have died, let's say at home, which we have a few, patients that refuse medical treatment, and I have several of those patients in their 50s, they think they're strong enough, they have a fever, and let's go to the hospital, no, I don't want to go, and so on and so forth, and all of a sudden they died. I have found that they have the classic ARDS with the membrane formation. However, we've seen in those type of patients as well significant development of microthrombi in the lungs as well as in other organs. And let me finish because I know there's a question that I was trying to type. Are there any other findings? I haven't seen in the brain, it's been described, and we're waiting for results for neuropathology. I haven't seen in the liver other than some areas of microthrombi, but nothing that significant. In my opinion, it's lungs, cardiovascular, kidney. To me, those are the 3 major systems that I've seen being affected. Not to say that it could occur in the brain, and even immunohistochemistry has been performed. I know that, and it's been positive. But to me, it's lungs, heart, kidney. And that goes with the patient's comorbidities. Like I said, 7 out of 10 our patients have hypertension and diabetes and morbid obesity. And so you take those patients as they come. So there's one size doesn't fit all. I think you have great variability in the type of findings you have, for sure.
Okay, thank you, doctor. Other question about cremation. Is it, could cremation really eliminate the virus?
Yes, it can. For us in the city, you have to take into account that this is a federal government. every state is independent, let's say this. And I have practiced in Pennsylvania and in Michigan before coming to Washington. And in Michigan, cremations as a means of public disposition was not allowed. Still is not allowed. But in Washington, it is. So let me put it in this context. Somebody dies and it becomes my jurisdiction. They are here. So we offer the families, aside from COVID, the choice of doing a public disposition. So the city will bear the cost of that. And once a year, we do a burial of those decedents. During this pandemic, what we did is the city offer free cremation. So the city is taking the cost away from the families. So that the family can make a decision, but it's entirely up to the family in the city of Washington. If they decide not to go that route, they can choose a funeral home and then do it their way. What we have done in order to try to minimize risk is as soon as we pick the decedents from the hospitals, we sanitize them, we use double bags, sometimes triple bags, and warn the funeral directors. That's why we have a separate location just for COVID decedents. So the funeral homes, we provided them with PPE, we provided them with a package where they could proceed and not having the fear of infection. And it worked very well. Does the cremation decrease? Absolutely. That will be my preferred method, but it's individual. Personally, as a forensic pathologist, I don't think that the bodies they're going to contaminate the pathologist if you use universal precautions, because every day we're confronted with patients that we do not know what they have. They could have HIV, hepatitis B, hepatitis C, tuberculosis. We don't know. So it's a matter of using universal precautions like in every autopsy. However, that's different from the community because there are cultural sensibilities and sensitivities in the sense that in some areas, the families wash the bodies, the families manipulate the bodies, and there may be a risk there. But personally, in the normal course of business in a forensic setting, if you use universal precautions, I wouldn't be worried. Now we have the luxury, and that was one of the questions, and I'm sorry, it's just been long-winded. I have been performing autopsies on the biosafety level 3 autopsy suite. That's a suite with negative pressure. So that is a luxury. Of all the medical examiners, only 2 in the United States have that suite. But I'm doing that not out of fear that the body will contaminate me. It's just to protect my staff. So they feel that they are protected, and we have ventilation with the protective equipment and so on and so forth. But personally, I could go now and do an autopsy in a regular way. Personally, I have no problem that but with the pandemic, a lot of fears have been risen out of this. I don't think that the bodies are radioactive and so on and so forth. I don't think that they are that contagious. Having said that, you have to take into account, I've been living in the United States for 30 plus years, but I was born in a small country in the Caribbean, the Dominican Republic. In the Dominican Republic, people tend to manipulate the bodies. They like to do the funerals at home and so on and so forth. They like to watch the decedents. I think that could be a problem, for sure.
Yes, Dr. Diaz. It's also a problem here in Indonesia where people here because of religion requirements that people who disease need to be washed properly according to the religion. And some of the question is really actually, how long will the virus stay in the body after the patient died?
I think it's 24 hours, but that's an arbitrary designation based on my experience doing the post-mortem swabs. And I think it's a little bit less in humid and hot conditions. I think during the winter, I think it's a little bit more. I think it could last 36, 48 hours. I have a patient that came back, well, not a patient, a decedent, that came back positive. And we know for a fact the last time he was seen. And it was approximately like 67 hours, and he came back positive. And that was at the very early in the pandemic. but the temperature here has been like the equivalent. I don't know if you use centigrades or Fahrenheit, but in centigrades was like 36 degrees centigrade with 99% humidity. I think in those conditions, somebody in a house or in the street, I don't think the virus will survive more than 12 hours. But all that is anecdotal. You have to presume that the virus is there.
Okay. So basically humidity and weather plays a role in the virus, but we cannot make it for sure. So it's better not to touch the body after the patient died. Is it correct?
I would, yes, I would agree with that. Absolutely.
Okay. Okay, thank you, Dr. Diaz. Next, perhaps I will proceed to Dr. Vinci. Dr. Vinci, some question is, how can we prevent disease spreading in the house? Because there's a lot of question lately about the host cluster, family clusters. How do we prevent the spread of disease in our own house? Should we use mask every day, or what is it?
Yes, thank you, Dr. Dian. It's very hard to prevent the spreading disease inside the house, especially if we don't know if this one person in family has a virus or not, because it's very hard to use a mask inside their house. I think I don't know if any person would use in the house a full mask for the whole family. I don't know. I don't know if anyone will ever do that. And so how we prevent to get the virus in the first place that's the important way to prevent to get the virus inside our home actually. But as healthcare workers like myself and probably many healthcare workers, we have the highest chance to getting the virus inside our family. That's why, or the best way to prevent the virus getting to our family, that's we avoid our family actually. And probably if you want, you can use masks inside your home. As a doctor, probably it can help prevent the virus to get into your family. Probably ventilation can be helpful too, but well, there is other way like getting shower before getting home in your hospital, and probably it can reduce the virus outside your body. But how about the virus inside your lungs? How about the virus on your nose? It cannot be get ridden by that. So the only way is just using masks. If you really want to make sure your family is safe, as a doctor, as a nurse, or other healthcare workers, or probably by separating the family with comorbidities. Like I never contact my parents since March, probably with using just phone or face chat. I mean, well, that's another way. But for another way to prevent inside, if we already have the virus, there's a highest chance to get the virus for all the family if one family has the virus. Probably I see in many of my patients, if one patient is already inserted in hospitals and we check the entire family, there's so many of them is already positive also. By the time we know that one patient has already has symptoms for 7 days, well, that 7 days, they already spreading the virus for whole family actually. So probably it's already too late if we have the patients come to us as a doctor and they already have symptoms for 7 days, and that 7 days is already enough for the virus to spread inside the family. So it's actually very hard. So probably the one way to use an air purifier probably, but yeah, I don't really sure it can really reduce the amount of virus inside our house, because it needs very expensive and very, I say it's very big room air purifiers. It's very expensive for most of in our home to use actually. Probably it can be used inside one room, probably for 30 meters square. it's common, but it can be used in one room only. But in the whole house for air purifier is not possible actually.
Okay, Dr. Finchi. Other questions is how do we educate people which is doing self-isolation at home, especially someone who is being discharged from the hospital with still positive swab?
Yeah, if the patient's already isolated in hospital, probably already relief of the symptoms, so the amount of viruses probably is already so small to be spreading. Like I said before, at the first 7 days before the patients came to the doctors, they already spread to the family actually. So I think it's already too late to prevent the virus spreading inside the family by the time they already get the virus. But after we discharge from the hospital and we tell the patients to always use the mask, they will do that. But I think it's enough for the patients only to use the mask, not the whole family. And we can separate them in one room and have the good ventilation in that room. So physical distancing actually, physical distancing and using a mask and ventilations, also like that. So probably can help. But by the time they already discharge, sometimes around 2 weeks, most of the time I treat my patients, the virus viral load is probably already low enough to very hard to spread to the other family actually. Especially if we use masks on the patient, it's very low chance to infect the whole family.
Okay, Dr. Finchi. So next, since Professor Feng-Ming Luo is unable to attend discussion, we will proceed to our overseas moderator, Dr. Ogi.
Yes, can I help?
Do you have any open question for the participants? For the panelists.
Okay. Most of the questions has been answered by all speakers, and let's see what we have now. Okay, question from Dini Irawan to Dr. Melvin. Maybe Dr. Diaz can also try to answer this. Dr. Melvin, how do Singapore keep the death rate low? Do you have any suggestion or opinion about this? Thank you, Doctor.
Okay. Okay. Let's. I think the death rate is it's artificially sort of made low because we have a lot of patients who were infected in the dormitories, which is very unfortunate. But regardless, is it okay if I share a slide, if you don't mind?
Sure, Doctor.
Yeah, just give me a while. So I wanted to continue the part on my talk. So anyway, I will just try to share this slide with you. Let me see, where is it? Okay, anyway, this is this is a manuscript submission, okay, but everybody has been asking us why we have kept our ICU, our mortality so low. So just to let you know, actually in Singapore, only lopinavir and ritonavir, and then remdesivir were the two drugs used in our patients with critically ill from COVID-19 ARDS during the large part of the pandemic. And eventually the protease inhibitor was eventually found to be ineffective, and then even remdesivir is only improved recovery time in hypoxic patients with no good survival data yet. And then of course when dexamethasone came out, and then it was shown that the benefit was greatest in those receiving mechanical ventilation. But it's very interesting because if you look at the time point, the results of the recovery trial were released on the 17th of July. And during our time already in Singapore, on the 13th of July, we discharged. I think that was from NCID. The Singapore discharged its last COVID-19 patient from the ICU. And since then, from then until now, because we have a daily report, like Professor Diaz was saying, you know, we all have all this daily report. Only one more patient needed ICU care, and that was for 3 days in mid-August. And if you include, okay, at the point of writing, I mean, we've submitted this for the manuscript for review. There have only been a total of 27 deaths, and so far about 129 ICU admissions. And that means that the overall ICU mortality rate is only 21%, and this is still likely to be overestimated because there were patients that we deemed, you know, to be severely ill, but were not candidates for ICU care. So, and this was still much lower than the 22.9 in the treatment arm of the recovery trial, and when that was testing dexamethasone. So what is the point that I'm trying to say? It's I think if you read my slides, it's just a personal opinion. At the end of the day, we should not be getting too caught up with all the therapeutics, because there are a lot of therapeutics which are under investigation, right, or have been proven to be not very significant. Even dexamethasone, like I said, we didn't use that. Our death rates were still very low. I think at the end of the day, to very good management of good ICU management, general ICU care, right? It must be the intensivist must have a good understanding of critical care physiology, right? Managing whether lung mechanics, mechanical ventilation, systemic oxygenation, hemodynamics. I think all these are a lot more important in impacting the eventual outcome of patients who are very ill from COVID-19, rather than everybody is trying on new therapeutics, because there have been so many. But why is it that we are not doing things that have been tried and tested, right? Things that we've been doing well all along, rather than always pinning our hopes on the next new agent that will cure the disease. But it's like any viral illness. It's just an influenza. At the end of the day, it's going to be, right? Just like, yeah, we don't have a very good treatment, but everything is supportive, and supportive means very, very good and excellent and high quality general intensive care. But that's my opinion. Yeah. Thank you.
Yeah, thank you, Dr. Melvin. Dr. Diaz, how do you find a death rate in America? So far, we know that America is the first number for the COVID-19. So do you have an opinion for this?
I do. I think it's a combination of factors. The most important one, in my opinion, is the significant population that is high risk. And I have emphasized here the comorbidities. And we talk about the COVID-19 epidemic. United States has an epidemic of morbid obesity. It's not uncommon in the United States. I'm not familiar with the metric system, but it's not uncommon here to have people in excess of 400 pounds. That would be, I don't know, 200 kilograms. It's not uncommon at all. That's the new normal. And we are seeing that those are the patients more affected. That's number one. I think in a city like Washington, I think we were a little bit ahead of the curve, because the first cases were in the West Coast, and then it went to New York. And then the epidemic basically developed in New York City, and you saw a huge number of deaths. And that's the city of Washington took preventive measures. Now, but this is a very unique city in terms of the population, in terms of the type of people that live here, and so on and so forth. I think it's a whole different scenario once you go to other areas. The United States is a country that its citizens pride themselves in individual liberties and freedom. And a lot of American citizens think that it's an infringement upon their freedom that the government imposes them to wear masks, for example. And that's been an issue in a lot of states, such as Florida. I'm going to go to the beach no matter what, and we're going to have parties. And colleges have seen a lot of outbreaks. So I think this is not a homogeneous country. This is a country with a federal government that doesn't have the capability of imposing mandates, public health mandates, because each state imposes them. And so it's been a struggle. And I think, to be honest with you, I think the country itself as a whole was not prepared in terms, what this epidemic has brought forth is the need of epidemiologists, the need of specialists that do contact tracing. And I think in that sense, the city of Washington has done a very good job. When they were talking about, contamination at home, we have several cases at the beginning of people in denial. A member of the family had it and died. And then 6 or 7, they didn't want to get tested. But at the end of the day, they tested positive. So the city of Washington has done a tremendous job in terms of doing contact tracing. But we need a lot of epidemiologists for the second wave, if a second wave is coming. And somebody asked on the chat about if my concern about the fall in November, December, we have a downward trend in Washington. I'm concerned of what I've seen in Spain and Italy and France, that the cases are increasing, and we'll see. We'll see what happens. But I think it's a combination of factors. And I think the most important one is our population with a lot of comorbidities and another segment that don't want to comply or don't believe that preventive measures are effective. Still, there is a debate in the United States about if wearing a mask is effective or not. So.
Okay, thank you, Dr. Diaz, for the opinion. Dr. Dian, do we still have a time for the question and answer discussions, or?
No, unfortunately, we're running out of time.
Okay, unfortunately, we cannot please for any participants that have been throw their questions to our speakers to get answer, but we try our best to complete and to fulfill the answer by maybe we have email for to all the speakers right now. And for the closing statement, I have one closing statement. Maybe I can show you. Oh, the post test will be opening after this. Is that correct, Dr. Dian?
Yes.
Okay.
After the discussion session.
Yep, and to all participants, you can see the link in the chat or in the Q&A column. So today we have learned and absorbed precious knowledge from not only one perspective, but it's multi-combined perspectives. It is the same main topic, which is the COVID-19. From the clinical pathology assessment by doing a serology test to see more deeply into an advanced oxygen therapy for very ill patients, even to take a lesson from someone with COVID-19 who has been passed away. We do believe as a physician and scientist, some action must be taken to diminish this disease. However, we should put this matter together with the local and central government, putting this matter as a very serious matter. To all participants, to all speakers, I would like to say thank you very much to join us in the second international webinar. I hope I can see you in the next time.
I also would like,
Dr. Dian.
yes,
thank you.
I'm sorry. I also would like to thank you for the participants. We have 2,372 registered participants and 1,352 online attendees. Thank you very much. And now I'm going to return to Dr. Jaka. Dr. Jaka Pradipta, thank you for all the panelists, and we hope to see you again in another webinar or perhaps in RESPINA Symposium in Indonesia. Thank you very much and good evening.
Thank you very much, Dr. Dian, Dr. Xiaogi, and all of our speaker. It was a very interesting discussions. And now we have reached the end of our webinar. If you have registered, please remember to fill and submit the post-test for electronic certificate after the webinar with click the link in comment sections. Thank you so much for joining us in this webinar. More than 2,000 people from all over the world has joined this webinar, and we hope everyone gets valuable knowledge today. Amazing. Thank you to Daria Faria to support this webinar with a very well coordinations. Good night. See you again in another RESPINA webinar. Wassalamualaikum warahmatullahi wabarakatuh. Bye.
You make me move, you make me dance, you make my heart beat super fast. You lift me up, you make me laugh. Baby, you're the best I ever had. You're the best I ever. You make me dance, you make my heart beat super fast. You lift me up, you make me laugh. Baby, you're the best I ever had. You're the best I ever had.
Resistensi antibiotik adalah kondisi ketika suatu strain bakteri dalam tubuh manusia menjadi resisten atau kebal terhadap antibiotik. Resistensi ini berkembang secara alami melalui mutasi evolusi acak dan juga bisa direkayasa oleh pemakaian obat antibiotik yang tidak tepat. Penggunaan dan pemilihan antibiotika yang tidak tepat adalah penyebab umum resistensi antibiotik. Untuk kasus infeksi dengan komplikasi, pemilihan antibiotika yang tepat sangat diperlukan. Dariafen, Doripenem 500 mg IV. Dariafen, Doripenem 500 mg IV. Terbaru dan paling poten di kelasnya untuk kasus complicated intraabdominal infection dan complicated urinary tract infection termasuk pyelonephritis. Dariafen Doripenem 500 mg IV memiliki struktur sulfamoylaminotil yang bertanggung jawab melawan bakteri dengan cara menghambat sintesis dinding sel bakteri dan menginaktivasi penisilin binding protein. Dariafen Doripenem 500 mg mempunyai aktivitas in vitro seperti gabungan golongan penem lainnya dengan MIC yang lebih rendah. Dariafen Doripenem 500 mg paling poten di antara karbapenem lainnya, broad spectrum dan efektif untuk penata laksanaan complicated urinary tract infection pada bakteri gram negatif multiresisten. Dariafen Doripenem 500 mg IV. Attack Noda for complicated infection.
Nyeri pada dada. Sulit bernapas bagaikan berada di dalam air. Merupakan beberapa gejala yang dialami oleh penderita pneumonia. Pneumonia menginfeksi 450 juta orang per tahun di seluruh dunia. Singkirkan kekhawatiran. Nafas baru dalam terapi pneumonia telah hadir. Moxifar. Dengan kandungan moxifloxacin yang direkomendasikan untuk terapi community acquired pneumonia, Moxifar efektif memperbaiki gejala-gejala community acquired pneumonia. Moxifar aman untuk pasien usia lanjut dan gangguan fungsi ginjal. Moxifar lebih cepat mengatasi perbaikan klinis dan tingkat kesembuhan pada pasien. Moxifar, it's time to breathe relief. Moxifar, breath of relief.
Told you once, Get your head